So I appreciate the chance to come and talk with you today. This is really an exciting opportunity. It's very interesting for me to see the sort of the interplay between one of the panels really talking about the clinical research that's going on. Certainly our colleague from the other side of the country talking about what's happening at the federal level, and giving us the chance, giving me the chance to talk to you a little bit about what's happening here in California and to frame the opportunity that I think is built into the Mental Health Services Act. And that's really what I want to do. But I want to put it in context. And I want to shape it a little bit in terms of some of the things that you've heard. And it's very interesting to hear the gentleman from Maryland talk about their reporting system. I staffed legislation for the Senate a few years ago that would require California to move towards outcome-based budgeting. In other words, every program in the budget over the course of a decade would have to develop those kinds of metrics and outcome measures. And we talked about what was happening in Maryland and in Virginia and in Washington and in Oregon and all the things that are going on around the country, because there's some phenomenal things that are happening in terms of how the public sector is using data and analytics to shape and guide decision making. And we struggled mightily to get that legislation to move. And it was through the forcefulness of the author, Senator Wolk, on the Senate side, and some crafty maneuvering on the Assembly side to put that bill on the governor's desk, and he vetoed it. And because he pointed out that he doesn't need legislation to actually shape the budget process, but it gets at this issue of what drives decision making and culture and the uptake of new information and data and analytics in terms of the policy decisions. We're not yet at a point culturally in the policy world where the most important factors that are driving decisions is research and analysis. And I think you heard that. There was a discussion, the gentleman over here talked about the long-term injectable strategy, so the effectiveness of that. And I asked the question to Ken and some others sort of during the lunch break, because man, it seems to me that there would be a fiscal incentive for the public mental health system to move in that direction, because the treatment compliance would go up, costs would go down. But the story that I'm hearing is, no, in fact, it's actually been really hard to get counties and community providers and others to actually adopt an evolving strategy that has effectiveness data, particularly with, as you indicated, there was no treatment resistance whatsoever, or marginal. You may not have said whatsoever. So I appreciate the chance to come and talk with you about kind of the environment that I see that we're in California in terms of mental health system, particularly around the intersection between research, science, policy, and programmatic decision making. All right, so to do that, I'm going to provide some context. I want to outline the framework of the Mental Health Services Act, what I call sort of its genetics, its DNA, because I think we sometimes forget that. And because we forget that, we don't see the opportunities that it creates. And then I'll talk a little bit about some of those opportunities. But I was writing down sort of some keynotes. You know, this Senator Steinberg, Darrell talked about, we're on the cusp of a movement. Stigma, resistance came up, evidence-based practice. This idea of a learning community around health, absolutely. The issue of insufficient political capital and attention, performance-based management, and outcomes and measurements. Those are the themes that really are peppered throughout my presentation, and it seems to me those are the themes that are going on today, and those are the themes that are actually built into MHSA that are really intended to result in the kind of transformation that you're all talking about. But we have some challenges, little challenges. All right, so if you step back, and Darrell mentioned this, if you go back to the 1990s or in the 1980s, we knew back then that our mental health system was not ideal. I did an analysis of the mental health system in 2000 for the Little Hoover Commission, and we said, Houston, we have a problem. Our community mental health system is rationing care. There was such tremendous resource scarcity that we were rationing care, and the way that the Little Hoover Commission characterized this, based on testimony from family members and consumers and clients, was that if you knew you had a mental health need, you weren't sick enough to qualify for care. That was the perception, right? And someone said, we would never do this for cancer. And it really was this idea that if you're not in stage 5, you're not eligible for care. We would never, ever say that in the physical health world. But that's the level of resource scarcity that we were at in the late 90s. There was this, this notion, we'd ask this question, how do we improve the quality of care county by county? And family members said, we know how, we move. If the quality of care isn't as good in your county as you want it to be, the number one strategy is to move to some place where they've figured it out and they're doing it better, right? The concept of prevention was well understood, but there was no expectation, no notion that it was a viable option because of lack of money, right? Even today, with $1.7, $1.8 billion coming in, there are fights over whether or not dollars should be allocated for prevention while people who need direct services are on waiting lists, right? And so, but back then, we really weren't talking about prevention because nobody thought this was something that we could invest in at the time. Again, resource scarcity. And I would say most importantly, there was little opportunity for improvement in the sense that there wasn't a lot of hope. There wasn't a path. I worked with Yolo County at the time. They were trying to restructure their mental health system because of a budget deficit. And I called the Department of Mental Health. I worked for the Little Hoover Commission, and I said, send me your best people who know the community mental health system the best, because Yolo County is looking for models. And the response was, well, first of all, we don't have anybody. And second, we would never come if we did, because if we show Yolo County how to design their system and how to fund it, and we face an audit exception from the feds, we'll be liable. So Yolo County's on their own. It was really a dramatic time when there was not a lot of aspirational goals. There was not this sense of we can do it, that we didn't have the kinds of partnerships. In fact, we sort of, as a consequence, it really was resource scarcity. This wasn't about people making bad decisions. This was about people being put in really untenable situations. There was intense competition for growth dollars, right? And we were practicing what I like to call competitive cost avoidance. That's not my expensive patient, that's yours. So I had a conversation with someone out of the governor's office who said, well, isn't it just cheaper to lock these people up? Because at the time, it was. At the time, from a fiscal perspective, from the perspective of the colleagues of those folks from the Social Security Administration who aren't thinking about it in quality of life or life years, this is about the bottom line, we were in pretty dire situation in terms of funding. Prevention was an unaffordable luxury. There was a mismatch between investments in prevention and where the savings accrued. Mental health would say, gosh, if we put money into mental health diversion programs, it saves the sheriff money, it doesn't save me money. If the counties invest in keeping people out of the criminal justice system, it saves the state money because those people went to state prison, it didn't save the county money. There really was this fiscal conflict built into the system that we have. And that resource scarcity really undermined trust between the state and the counties. It prevented collaboration from health, welfare, and related programs. We did not see, people weren't coming together and singing Kumbaya, right? It really was this, and quite often the battles were the biggest between sister agencies, mental health versus social services, at the state level and at the county level, the criminal justice system versus mental health. We still see that today. School educational dollars, who pays for the mental health needs of kids in the K-12 system? Is that a school dollar or is that a mental health dollar, right? We heard that today. Daryl talks about the mental health needs on our college campuses, right? We have some county folks here. I can't imagine, even today, with the amount of money that we have, that the counties are really looking forward to sitting down and figuring out how they can invest more county dollars into our CSU, UC, and community college campuses, right? Not because we don't agree that there's problems and needs, but it's the dynamics of the system. So, the last thing I would add, and it's consistent with that comment about the Yolo County conversation, is leadership at the state level was strained. It was limited for a variety of reasons, and it wasn't about any individual, but it was about sort of whose job is it? Is it the county's job to fix this system? Is it the state's job? Is it the legislature's job? Is it administration, right? All of this in the context, as Daryl says, is mental health was schools, roads, right, higher education, clean air, the environment. I worked in the legislature for 7 or 8 years altogether, And as he said, the worst bill is the bill regulating dogs on the beach, or the ferrets, or mental health is just down low, right? Yeah, don't get between, don't go out there when there's a rally on legalizing ferrets in California. There really were disincentives for the state to help guide improvements at the county level. All right, so that's really where we were 15 years ago. And many of those concerns exist today. But the pressure prior to the MHSA on the system was much more dramatic than it is today, right? We have better incentives now for prevention, early intervention, for innovation, research, collaboration. There are greater expectations. One of the things that's really interesting, and I think it's coming out in some of the conversation today, and I think it's a healthy thing, is the bar, the political bar on mental health has been raised dramatically because of the Mental Health Services Act. And it's been raised higher than is true for other areas in public policy, right? So I get phone calls from the press of, where's that dollar going? Why did San Francisco County invest $20,000 in a program that may not be the most effective program, right? The level of scrutiny linked to the level of hope in terms of transforming the mental health system in California has just shot through the roof. And I'm often the target of some of that in terms of the Mental Health Services Act and what our job is, or I could point at Commissioner Van Horn, one of my bosses, who stands behind me, and I can step out of the way when it comes to that target. But the standard has really been raised in terms of our expectations, and that's a good thing. All right. So I want to talk a little bit about the genetics of the Mental Health Services Act, and some of you know this, but it sounds like from some of the comments that some of this is new. So since the Act was passed, the new investment that was made has been about $15 billion. That's a lot of money. It's about a fifth overall of overall mental health dollars. But it's a relatively, this year, the $1.7, $1.8 billion that'll come in through MHSA is a significant amount of money. But let me put that in the context of $125 billion in health and human services overall. It's a very small percentage of overall dollars that are available to deal with the big issues of homelessness and incarceration and suicide and health outcomes. But it's a really important piece because of our ability to leverage the design of the Act to drive improvements the way that you're all talking about. To my knowledge, this is the biggest and most visible area where the state of California requires an investment in prevention. I worked at the Little Hoover Commission for almost a decade looking at all kinds of public programs, always talking about prevention, 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 prevention. And it was always, there's no money, we can't afford that. MHSA requires prevention. About $3 billion since the Act was passed. And we require innovation. And the reason that the innovation was written in the Act by Daryl and Rusty and others really is because there was this recognition that if we don't begin to try things and do things differently, we're not going to get out of the mess that we're in, right? About $500 million. Actually more than, it's something $550 million for innovation. That's a lot of money. And other than some of the innovation that goes on at the federal level, innovating in the public sector is not something we do normally. It's not necessarily something we're good at. It's so new, it's so different, it requires us to take risks. And the public sector and risk-taking don't always mix well, right? So those concepts, new investment, prevention, innovation, and I would add a mandated research and evaluation approach, right? It's not optional. That's also very different for the public sector. This is drawing from lots of experiences of things that have worked in lots of areas, including from the private sector. But the Act is a learning body of policy. It was built around a set of concepts consistent with this notion of creating a learning community around health, that the expectation is we'll get better. That's very different from almost every other policy area, certainly in the state of California that I'm aware of, where by design, change is built into the Act. There's a mandatory investment in research, a mandatory investment in innovation, and a strong emphasis, 20% of the dollars, for prevention. So those concepts, which if you add in the design of the Act, which requires a community consultation process, and requires that, emphasis on evidence-based practices and learning, we really have the opportunity to fundamentally transform how we do things. It's a rare combination, and I would add research and analytics are part of that. And I would suggest that what we've really done is that Mental Health Services Act is positioned to move California away from this sort of reactive set of policies that are really trying to incrementally think about what's happening budget year to budget year. That came up, that legislators think on a fiscal year cycle, budget year to budget year, to actually being a dynamic system that is intended to evolve. The concept is phenomenal. The practice, we're headed in the right direction. We are a startup in many ways in terms of the practice. But I want to just, I cannot emphasize enough how unusual it is to put together the components of the Mental Health Services Act and to create that opportunity. Now, for this year, so the projections are about $1.7, $1.8 billion. That means about $340 million for prevention and early intervention, and about $85 million for innovation. That's a lot of money. I mean, it's not a lot of money in terms of the scale of need. It's not a lot of money in terms of the overall 120-something billion dollars this year. But who thinks we can do a lot with $85 million to innovate in a single year? And if you add the money up, counties can use those dollars over the course of several years. We have a pool of funds that is going to approach about $400 million just for innovation, just to try things, just to experiment. And that includes experimenting on ways to evaluate, experimenting on ways to do research, experimenting on ways to do research and analysis and to communicate and to tell that story, right? All right, so that's the opportunity I want to talk to you about. And what's really important is how do we leverage those dollars, whether it's the $1.7 billion that is overall, or the $85 million for innovation, or the $340 million for prevention. How do we leverage that both strategically and collectively? And that's what I think you're hearing from Daryl, is that that's where we're not there yet. Because the design of the Act distributes 5% of the money goes to the state for state administration, up to 5%. And the balance goes to the counties. 95% of the money goes directly to the counties. It's distributed based on a formula. There are certain requirements, 20% for prevention and early intervention. The bulk of the money is for community services and supports. Half of that has to go to full service partnership. But because we're distributing the money to local mental health agencies, we've struggled to be strategic and collective in how we innovate, in how we do the research, and how we bring together the data and the analytics, and how we tell the story, whether it's on the prevention side or the innovation side or the service side. And I point that out because I think it's really important to recognize that in the last few years, not because of realignment in '91 certainly, but with the Mental Health Services Act and with the more recent mental health realignment where we shifted more authority to the counties, the fiscal incentives that were so problematic 15 years ago are now better aligned. In other words, investments in prevention at the county level have the potential to pay off at the county level. We have more opportunity to work together collaboratively because of the way these programs have been realigned. The counties have done a phenomenal job of stepping up and evolving in this really different policy and governance opportunity. In many ways, though, the role of the state has changed, but our behavior hasn't. We continue to operate as if we're a statewide system, and we don't yet have the tools to work collectively through this distributed governance model. Any public administration faculty and students in here? None? Not a one? All right, we have two. Woohoo! We really have a distributed governance model. It's a very different model. But we continue to think about California as having this unified, centralized command and control sort of strategy. And when we see things, as Daryl points out, of needs not being met on our campuses, or the difficulty of integrating the research that's happening across all of the research centers in California, we sort of step back and say, well, gosh, we could do more centralized command and control sort of models. I want to put on the table, there are other alternatives out there, and we need to figure out how do we become more collectively strategic? How do we become more intentional as a community to recognize the opportunity that the Mental Health Services Act creates for California? And if we are successful in that, how do we do it in a way that drives change, not just in the 1.7 billion, not just in the overall mental health dollars, but in all of these other programs that come to play when we talk about the overall outcome issues, right? The goals of the Act include reducing incarceration, suicide, reducing unemployment, right? Improving educational outcomes. These are all, the mental health system is making a foundational investment in quality of life. And if we can begin to design strategies to bring in the expertise that's in this room, that's around the state, if we can get past some of those fiscal disincentives, some of the issues of low or weak or trust in terms of the state or the counties, or our health, mental health, criminal justice, education counterparts, right, where we don't have, this is about culture change. It is about creating a social movement, but it's also about culture change within the systems that we have. Then we can be successful. And so I bring that up because I think we're still working on the role of the state in a couple of ways. So the issue of parity came up. In 2000, when this analysis was done, we recognized that if we're just trying to address our mental health needs with public dollars, we will not get there. There's too much pressure on the system. And it is always, I'm not a mental health expert. I'm a policy person, and if you read my bio, my PhD's in sociology, and I worked in Central America and rainforests. But I can tell you that it surprised me that if you have a child and you want best quality care, you often look to the market for something other than behavioral health, right? Nobody says, Grandpa needs a heart transplant, let's get him signed up for the county clinic. But if you have a child with a behavioral health need, we're getting into a county program. Best in class is public sector. Now, the Canadian might be offended, but we don't think in the United States that best in class is public sector. For those of you in the public sector, please don't be offended. That's just sort of, when it comes to innovating and improvement, we typically don't think of the public sector as, leading the curve. But when it comes to behavioral health care, that's the reality. Best in class is public sector. We have to figure out, and I think this is the role of the state. The counties can't do this. They don't have the ability to speak with one voice in the same way that the state can. We can partner with the counties and speak together, but we really have to think about what's the role for the commercial insurance sector in terms of putting more money and creating more resources and creating more opportunities, as well as driving continuous quality improvement in terms of the behavioral health system. Workforce, that came up. Again, we've distributed dollars down to the counties, and the counties are now the center of the universe, but the counties aren't in a position to address the workforce challenges that we have in California. And the comment was made that in San Francisco, cultural competency, you want to hire someone who speaks 4 diverse languages from rural Mexico and is a clinician, you better be paying top dollar, and guess what? Right? That's a real challenge, right? We have tremendous workforce needs that are not being met. Data strategy, right? Here's another area. So we're looking at 4 facets. The Oversight and Accountability Commission is looking at 4 facets of a data strategy. Open data. How do we gather data and make it available? Consistent with the comment about the woman in Iowa who says, hey, I've been sitting on this data for a long time. It's going to be put to much better use if it's available. And the federal government's done a phenomenal job of pushing the healthcare industry with their open data strategy because they recognize they're not going to get better. We're not going to meet our health needs simply through what the federal government can do. But what the federal government has and what the state of California has is a treasure trove of data. And we're not going to be able to hire, despite those of you looking for jobs, we're not going to be able to hire researchers to tell all the research stories. But if we can leverage an open data strategy and make that available to all of you, you can tell those stories much better than the public sector can. So we're working on an open data strategy. We're working on linked data analysis. We're trying to get data from EDD, employment outcome data. There was conversations about workforce outcomes. There's this tremendous perception that people with mental health issues can't work or don't work or won't work. But we know otherwise. We have to be able to tell that story. We have to be able to match criminal justice data and mental health data. I did work on this 10 years ago and published it in Psychiatric Services. It's online for free. But somebody put it there, it wasn't me. But we did this link that says we can do our homework and we can figure out what is the sweet spot in terms of diversion, in terms of research and analysis to keep people out of the criminal justice system, because it's cheaper to provide prevention and early intervention services before they go to court than to try to work with them after they get released and try to avoid recidivism. So we're working on a linked data strategy. We're working on being able to tell the story. So the biggest challenge we have this week is just letting you all know how much money is available county by county. And so Daryl mentioned a couple of newspaper articles that counties are sitting on hundreds of millions of dollars. And we don't understand the context for that, but the first step is to let people know how much money is available and what it's available for, because the Act says there needs to be that community consultation to start talking about what's the right use of those dollars. Well, if you don't know how much money is available, and sometimes it's hard to know how much money is available, but if you don't know how much money is available, it's really hard to have those conversations. So we're working on that. And then I would throw out there for the tech geeks that we're going to try to do some crowdsourcing stuff with some of this data, right? And that leads me to talk a little bit about innovation. This year, we will expect about $85 million for innovation. So the Commission reviews and approves all innovation programs. We just approved a $92 million innovation investment for LA County. So again, about $500 million for innovation. And the innovations we're doing are innovations light. They're incremental innovations, which are very important. It's really important that counties, talking with their communities, propose things that they want to try. And they're being conservative. They're thinking about, well, what's worked over here, and can we take that and apply it over here? But we also need some truly disruptive innovations. The model is that if we're not going to take risks and big risks, we're not going to get big gains and big rewards. And right now, it's a really challenging thing for counties to do, and we're not yet in a position to support them. But if we're going to transform this system, we really need to be thinking about how the Commission, how the state supports counties in their innovation strategy. And I think there's some roles for you in the room in a number of ways, right? Certainly, there's key opportunities at the intersection of prevention and research and evaluation. And you've heard that in all of these panels, right? And there's key opportunities at the intersection between innovation and evaluation. In some ways, it's about creating a backstop, making it okay for counties to take risks, making it okay and acceptable and, in fact, mandatory that they take risks on the prevention side as well as the service delivery side, to get creative, right? The reason why they're shy is because they've been burned in the past. And it's an evidence-based response. Put it in the context of this group, right? It's a very understandable evidence-based response to be hesitant, right? But we have to support them. If we want this act to truly be transformative, we have to make it not only acceptable, but approachable and safe. It has to be easier to try new things. It has to be easier to invest in prevention than it is not to do those things. And right now, we're not there, right? And I think this population, the kinds of events like this, building out these partnerships are an important way to do that. The last thing I would say, another area where we need to improve dramatically, is our ability to document the opportunities and lessons that we've learned, right? We have not done as good a job, the Commission, the state, the counties, I think, collectively, and I think it came out perhaps in this discussion of, did you write the research article, right? I chose not to go into teaching. I just was not good at the publishing thing. But those stories aren't the ones that captivate the decision makers that Daryl is talking about, right? We have to be able to tell the story in ways that actually shapes the political capital, the way that will be important when counties take risks and they fail, when there's a downturn in the economy and people are thinking of cutting these dollars, when we try something and it is controversial, something as controversial as yoga as a strategy for respite workers, right? I don't know if you've seen those articles that, it's so interesting, the story that exercise works, right? So if I put out a grant that says, okay, we're going to put $50 million available to help people with an early psychosis exercise, every reporter in the state of California would call me and say, are you kidding? Right? We have to get better at telling that story so that when those bad things happen, trust is there, right? We have to build that trust with the broader community. As long as this is a battle, a conversation, a discussion between consumers and family members and providers alone, it's only going to be consumers and family members and providers who are sitting around making decisions. And we do not collectively have enough political capital in that small circle to actually transform this system. We have to expand the field and engage the business community and taxpayers. You don't have to have a child in an elementary school to realize that high-quality elementary schools are important for this country. But it's almost as if you have to have a family member to recognize that the mental health system is a sound investment. And if we can't solve that problem, we're going to struggle mightily to solve the problems around quality and access, adequate investment in research, evidence-based practices. So that gets at our ability to tell the story of why sound investments in high-quality mental health programs are good for all of us, not just the few people that are sitting on the back of the bus that nobody wants to sit next to. It's about everybody on the bus. Mental health is about all of us, and we have to do a better job of engaging the community. So I would say there's an urgency on those two challenges, and I think Daryl reflected that. And I would add that there's an intentionality of the work that we're doing, particularly around prevention and innovation in California. And that's where I think where our hope is that intentionality of our system in California, to the extent that we can deliver on that promise, is what really creates hope, really creates the path forward. And so with that, I thank you very much for the opportunity to talk with you today. I see a tremendous role for the research community in helping us think about those analytics and helping us tell that story. It has to be believable. You have the credibility that sometimes those of us nobody says, oh, California state government said it, it must be right, but they do say, hey, UC said it, so it's probably believable, right? You have the street cred. We need to partner with you. We want to partner with you, so thank you for the opportunity.